Hello, my name is Dr. Jeffrey Barsuk. I am the Robert Herstick Professor of Medicine and Medical Education at Northwestern University Feinberg School of Medicine. I currently serve as the Executive Medical Director of Northwestern Simulation. I would like to welcome you back to another podcast in our series on simulation and healthcare education. In this podcast, we're going to talk about the use of simulation specifically in undergraduate medical education. I have the honor today of interviewing Dr. Michael A. Gisondi, an associate professor and vice chair of education in the Department of Emergency Medicine at Stanford University. Mike, it's an honor to interview you today.
Jeff, it's really a pleasure to be here. Thanks for having me.
So we always start our podcast with a little background information. So if you could share about your journey and simulation and how you got to where you are now, that would be great.
Yeah, I'm happy to. I probably should just preface with my path in medical education. I had the fortune of training at Stanford for residency and fellowship back when one of the grandfathers of simulation, Dave Gaba, opened his lab. So I have the distinction of being one of the very first learners to touch one of the very first mannequins that were available in the United States. And this is circa late 1990s. So I stayed at Stanford and did a medical education fellowship and worked, in that lab as part of a variety of different experiences in med ed. And I remember my first medical education research paper was one where we examined professionalism skills and GME learners, and it remains one of my most cited papers still today as my fellowship paper. But so I became a fan of medical simulation at that time, and carried it through a number of different roles, both as an associate residence director and then a residency director in emergency medicine, and now in my vice chair role. I think it's obviously has many benefits that you've talked about in your podcast for a lot of different learner groups. And we certainly can talk specifically about students today. I have, plenty of experience working with them and watching them grow in ways that perhaps other learner groups don't grow as quickly.
And of course, here at Northwestern, you had a tenure here for some time as a program director here before you moved to Stanford. And as you know, we use simulation extensively within our education curricula for the students. But, there's a lot to think about in undergraduate medical education with the entrustable professional activities and how simulation can help do the assessments with them. And I had a fortune of talking with Eric Humble in a previous podcast from the ACGME about how that can be used for the milestones and a little bit about the EPAs. But talk to me about what you do there at Stanford in the medical school and how you incorporate simulation.
Sure. Maybe there'll be two parts to my answer. I can speak a little bit to just how sim is incorporated in the medical student curriculum in general at Stanford. And my guess is it's probably not all that different than Northwestern or our peer schools. But then I can talk a little bit about how we've innovated around its use for assessing some of the more difficult to assess EPAs. And perhaps we can spend a little bit of time on that. But to answer the first point, there's, a very traditional lab at Stanford. It's the Center for Immersive and Simulation Learning, CISL, is CISL is its acronym. And the CISL lab is really divided into two quite traditional simulation labs. There's a half that looks like a virtual clinic with exam rooms that are quite traditional in their appearance and standardized patients. And those are primarily used in the preclinical years, though they're used a little bit in some of the clerkships later in school. But they tend to be monthly, if not more frequently, used throughout the practice of medicine course, which spans all 4 years, but is an intensive course throughout the first 2 years of medical school. And then the other half of the lab is more a traditional mannequin-based design with ICU rooms and ORs and emergency department rooms that allow us to simulate resuscitations and some larger medical codes that require us to use mannequins rather than standardized patients. Those get peppered throughout, not some, but not all of the clerkships. I know that emergency medicine, critical care, anesthesia, surgery, we all use it for those reasons. And there's a couple of high stakes exams that are probably worth noting in our curriculum as well. There's one that occurs at the end of the preclinical years, and it's a requirement to pass that high stakes exam to be able to move on to your clinical rotations. There's one that occurs at the beginning of the equivalent of a fourth year clinical clerkship that again is required to be able to move on to your fourth year clerkships. And finally, there's a capstone as well that I think is probably quite similar to the capstone program at Northwestern. Again, using simulation to be able to assess numerous EPAs, but not all of the EPAs, which I think is really interesting. And we can sort of talk about that as well.
So you're mentioning these high stakes exams that help you move on to the next level that you have to pass, which almost sounds like mastery learning again in some ways. But what kind of things are these exams assessing?
Well, for the transition from preclinical to clinical years, it's almost its own mini capstone, looking at your ability to take a focused history and physical, to be able to write basic notes, to be able to write out a problem list and some treatment options. So these are certainly students who haven't gone to clinical rotations yet, but they know mechanically how to do all of those tasks. And that way, when they're on their clerkships, those tasks aren't the impediment cognitively. It's the medicine that they're learning. So that transition from preclinical to clinical years really tries to capture all of those tasks of a physician, if you will. There's more clinical knowledge in the transition to between third year and fourth year clinical rotations, and you need to demonstrate some more medical knowledge during those exams, and it's less about the tasks of a physician, if you will. And then certainly the capstone is one would expect. It's a number of EPA based tasks, not exclusively EPAs. There's certainly a lot of capstone content that transcends EPAs. Some of that gets captured as well, but it tends to focus on those end of medical school. We have to dot our I's and cross our T's to make sure that you're ready to graduate. And those sorts of resuscitation based skills get demonstrated at that time.
So you mentioned that the students will take these high stakes exams before they're advancing to the clinics at the end of their medical school as well. What kind of things do they get to do to prepare for this? Is this kind of thing that they have scheduled sessions where they get practice in the sim lab to get ready for these? Or is this the kind of thing where they've had prior experiences in sim and they know what sim is all about, and really what they're learning for these high stakes exams they learn in the clinic?
Yeah, that's a really interesting question. So I think our students get two different introductions to sim. I think there's those preclinical years where they're learning the tasks of the physician, like I said, and some of those experiences introduce them to medical simulation, obviously for the first time in their educational journey, and they're going down to the virtual clinic space and working with standardized patients pretty frequently in a very scheduled basis. They're not going down on their free time, like maybe you would go to the library in your free time to study and check a book out at your own interest. They don't have that level of access to the sim lab, but they do have plenty of experiences such that when they're taking their first high stakes exam, it's not the simulation center or the environment or the SP that's unfamiliar. It will simply just be the case. Later in medical school, when they're in their clinical rotations and their test is much more content driven, those experiences are picked up in the clinical rotation, some of which have simulation. Some of our clerkships, as I said, will send the folks down during their clinical experience, on the students down to do cases primarily on the mannequin based side, and such content gets carried out into the later high stakes exams that occur during their clinical time.
for those high stakes exam, what then happens as a consequence if they're unable to meet the passing standard?
Well, obviously, we want all of our students to pass the test, and our students, just like yours, are very smart, capable people who want to succeed. Very similar to the mantra at Harvard and the way that they approach simulation there. These are earnest students who certainly want to complete the tasks in front of them. If they don't do so on the first try, there's obviously opportunities for them to study more and to come back, do that another time. I think it's very rare the student who would be hung up at this point in medical school and be unable to proceed. It's just that's unusual, but it's a question of how much time is required in a time unlimited fashion to be able to pass the test according to a minimum standard. And we're learning how to use these exams, to assess more than once some of the EPAs in our students, but some of them are kind of difficult to assess in traditional capstone. So we've come up with some creative ways to address that on the emergency medicine clerkship that I'm happy to tell you about.
Yeah, I would love to hear about that, because I understand the struggle as the EPA mostly is the end point of where you need to get, and it's up to the individual programs to determine how they're going to get there and how they're going to assess them, which I think is interesting. But I love the fact that more and more med schools are embracing this and learning how to incorporate these EPAs into things that are objectively measured, which is the key point here, is that using simulation and whatever assessment tools you use, requiring a passing threshold to move on to the next level, in essence, again, is a mastery learning type theory. Now we can argue it.
So I can tell you about two interesting projects that we coordinated out of the Department of Emergency Medicine recently that were led, honestly, by two of our medical education fellows, one a simulation fellow and one an education research fellow. The first, Cynthia Pang, built a very interesting online simulation platform that had avatars and students were the avatars interacting with patients that appeared on animated clinical screens. And we're able to assess a number of EPAs that had to do with making differentials and initiating treatment plans. And these were for traditional chief complaints from the emergency department of chest pain and shortness of breath. This was recently published in the Journal of Medical Internet Research, and you can see the interface. There's a link in that particular publication. It's Pang et al. In 2021 in JMIR, but it shows the interface and how we used it essentially to assess students' abilities to interact with simulated patients for those chief complaints. A second project that Danielle Miller, our education research fellow who just finished our program, she completed a similar app-based simulation looking again at chest pain and shortness of breath, but specifically for EPA 10. So EPA 10, we think, is the hardest EPA to assess. And there's literature that shows that EPA 10 is the least assessed of all the EPAs. There's AAMC data on this that's been published as well. So EPA 10 is the initiation of resuscitation, recognizing a patient in distress and initiating resuscitation. And you can imagine in a lot of clerkships, there aren't patients that are acutely ill and in need of resuscitation the way that you might find them in the ICU or the emergency department. So there's very few clerkship experiences really to capture data for EPA 10. So both of these fellows built online platforms to be able to try to assess those things. Even in an emergency medicine clerkship, a student may see a patient have a cardiac arrest, but it's really unlikely that the student's going to be the one to initiate treatment. And that's the way the EPA is phrased. So we have to find surrogate simulations that will help our assessors be confident that the student can complete EPA 10 to whatever standard that our school has decided to have. Now, that can happen in traditional mannequin-based simulation as well, but apps allow you to kind of change the chief complaint and change some of the data points with relative